Thank you, chairpersons, and thank you, organizers, Shyam sir and Dr. Paul. The topic which has been assigned to me is actually a difficult topic even for a medical oncologist, and the topic is to justify the role or to place the role of neoadjuvant chemotherapy for a hormone-positive early breast cancer. So let us start with that. How do you define an early breast cancer? Helps us to decide whether you are putting the bar at a node positive as early breast cancer, whether you are taking only less than 2 centimeter as early breast cancer, or you are taking as anything which is 1 to 3 nodes as early breast cancer. So we have to be very clear that how we are defining the early breast cancer. And for this talk, I will keep it as anything which is less than 2 centimeter or anything where the nodes are less than 4 or anything which is N1 as early breast cancer. Before I proceed further, we all have started to recognize an entity called low HER2. And yes, this entity is here to stay and it is a defined entity now. And as you can see on the charts, there will be around 1/4 of our patients in our practice where we now label them as hormone positive HER2 negative. Once we have the TDX like molecules which are there as an approval, there will be 1/4 of our patients who will be following this algorithm and going into a HER2 positive from an ER positive HER2 negative disease. Why neoadjuvant therapy for a hormone positive? Early control of micrometastasis when you have a luminal B disease, and these are two my indications that when I'm thinking of prescribing a neoadjuvant chemotherapy to a patient of a hormone positive HER2 negative disease, making BCS feasible. For example, a 4 centimeter tumor in a small breast lady, trying to achieve a PATH CR, which may or may not convert into any event-free DFS or OS advantage. Neoadjuvant hormone therapy, and then in the lab, following the dynamics of Chi-67, and then seeing that whether those dynamics help, and this is for purely a research purpose. And I will be very keen to follow the space of a combination of chemoendocrine therapy, which we sometimes do. That is a combination of capecitabine and letrozole, which we sometimes do as a medical oncologist in a metastatic breast cancer patient. To my mind, this is where the neoadjuvant therapy plays a role in ER positive breast cancer. So what are the prognostic and predictive factors? The standard prognostic predictive factors which we follow for TNBCs also plays a role in hormone positive EBC. The size, the grade, the histological subtypes, percentage positivity of ER, whether it is less than, whether it is 1%, 1 to 10%, more than 10%. Ki-67 in the ER positive disease, because we all know that luminal A and luminal B are defined majorly on the basis of Ki-67, and also the genomic signatures, which we always talk about in the adjuvant setting, such as oncotype, mammaprint, or CANACYST. So whenever you have in an early breast cancer, whenever you have a high grade tumor, grade 3, high Ki-67 more than 14%, weak ERPR say less than 10%, unfavorable genomic signatures, a luminal B subtype, and all these either 1, 2 or in combination exist, are to my mind the indications where I may consider neoadjuvant chemotherapy. Coming to the Cortazar et al. As well as one Makepeace, I think we all know these two papers. These are all meta-analysis of neoadjuvant therapy correlating with PATH CR. If you concentrate on the one which is in red, you can easily see that the PATH CR is also different in a ER positive disease when you have a grade 3 cancer, and that is quite well evident on the red mark that in grade 3 ER positive HER2 negative breast cancer, these may not be early breast cancer, but whenever they have been considered for neoadjuvant, the curves do differ. The second curve down is also the meta-analysis, where you see that in a luminal A subtype, there won't be any difference in pathological CR, but in luminal B, the curves separate not to a major extent, but to some extent like it used to separate in a HER2 or a TNBC. And thus, thinking in the mind that you will not be able to achieve a PATH CR in a hormone positive early breast cancer is a misnomer. You can achieve PATH CR by giving neoadjuvant therapy. Whether they convert into DFS or IDFS, that we don't know. This is a beautiful study. It is a phase 2 study, but a very good proof of concept study. If you see, they have done a biopsy, and on the biopsy, they have sent for a recurrence score, oncotype DX. They have divided the oncotype into less than 11, 11 to 25, and more than 27. This is what we follow as of today. And on the basis of this, if someone has less than 11 low recurrence score, they have given endocrine therapy, and more than 25 goes on a chemotherapy. Coming to the coming to the response rates, if someone has group A, if you concentrate on this, if someone has neoadjuvant hormone therapy recurrence score less than 11, 83.3% of the patients will be able to achieve the response. On the contrary, if you have recurrence score more than 26, then everyone is going on chemotherapy and 92% are achieving response rate. So this slide gives us proof of concept that whether we can incorporate these genomic signatures in our pre-operative setting, we can't do that, and I would love to see that whether we have clinical trials such in much more larger scales to adopt these genetic signatures into pre-operative setting. And once we are able to do that, what we talk about today about TAILORx and MINDAC and RX Ponder in the adjuvant setting, we wish we can use these cutoffs in the pre-operative setting. And if I have a 30-year-old lady who has a strong hormone positive with 2 node positive, or at least a 3.54 centimeter tumor, and I have data, I would wish to use TAILORx, RX Ponder, and MINDAC in the neoadjuvant setting. So suppose we decide this was the food for thought that where we can consider pre-operative settings. Now suppose we decide and we agree with in the tumor board that we have to give a pre-operative chemotherapy to this patient. So the question comes what to give and what regimen to follow. This is an age-old gold standard trial that overall survival doesn't improve NSABP 18. Everyone in this house must have gone through this slide that give you ASC before followed by surgery followed by AC. There is no overall survival advantage. Coming to the trial ABC trial schema, there are multiple trials on this slide. It is not only NSABP, this is NSABP 46, 49. The test arm was constant in all these trials. This was 6 cycles of TAC, that is triplet regimen, which we don't use nowadays because of toxicity. The comparison majorly have been anthracycline followed by taxane versus docetaxel and cyclophosphamide TC regimen, and then everyone has received endocrine therapy. Now, if you come to the pre-operative setting and you just concentrate on the hormone positive column, which is the topic of today, if you have a node negative disease, and if you concentrate on the invasive disease-free survival on this chart, these are these 2 values. Giving both anthracycline and taxane achieves a IDFS of 91%, and giving TC achieves 94%. That is because you are able to maintain a very good dose intensity and density with 4 TC. And thus, if I have to consider a node negative patient for an early breast cancer in a neoadjuvant therapy, I wish this data gives me some confidence to give only 4 cycles of TC and can avoid anthracycline, at least for an elderly lady or someone who has a cardiotoxicity. This is an interesting, this was about ACT followed by TC. The second paper is also an interesting paper. This is again a neoadjuvant trial of paclitaxel versus nab-paclitaxel. It is also known as ETNA trial, and there is also another trial of neoadjuvant setting, Pacli versus nab-pacli. If you see the pathological CR, in the complete trial set, it is 22% with nab-pacli and 18% with pacli. 4% difference in pathological CR. In luminal breast cancers, it is around another 4% difference in pathological CR, and thus it gives some hint. Though the difference in pathological CR is not to the tune of 10%, which we have been used to see, but yes, if someone is using a nab-paclitaxel in the neoadjuvant setting, he has the right to do so. Dose-dense chemotherapy, which is often talked about, we know that it reduces the breast cancer mortality by 4%, as seen on this slide. This is the Lancet 2019 famous PBCT-CG data set of 40,000 patients. And by using a dose-dense chemotherapy, we reduce the breast cancer mortality by 4%. Coming to the breast cancer mortality for ER negative, ER positive, if you concentrate on the right side, the ER positive breast cancer mortality is only 2% difference. And thus, I feel that subjecting a patient to subjecting early breast cancer patient to a hormone positive to a dose-dense chemotherapy is not justified. Now, response adapted therapy, I think there is enough of data set, and a medical oncologist thinks in a triple negative and HER2 positive breast cancer with the mindset of giving a pathological CR and using the response adaptive therapy? Can we do it in a hormone positive disease? For this, we have a CREATE-X trial where we gave CREATE-X trial had 48% patients who were hormone positive. We gave chemotherapy, pathological CR was achieved. If not achieved, they all went on capecitabine. Concentrating on the curve on the overall survival full analysis set, there is not much difference, but in the triple negative there was difference. So basically in a hormone positive breast cancer, which was contributing to the overall survival data set, the difference was not there, but when we looked upon triple negative, we saw a difference with a hazard ratio of 0.52 in OS. Thus in a hormone positive disease, giving adjuvant capecitabine if someone is not able to achieve pathological CR is not justified. The second trial, which is not talked about but presented at 2021 ASCO, is a very good recent proof of concept trial. Here, the patients with hormone positive early breast cancer as well as advanced breast cancer and were subjected to neoadjuvant aromatase inhibitors for 3 months. Then their E67 was studied. So the two as well as recurrence score was used as I suggested earlier. So a static marker of recurrence score was used at the biopsy. 3 months of hormone therapy given, and then a dynamic marker of P67 was used. A P67 less than 10% or a recurrence score less than 25, less than 12 was considered as low risk. That was only endocrine therapy subset, where patients with recurrence score more than 12 achieved a reduction in P67 to 10%, or they were having node negative with recurrence score 0 to 11 were subjected to endocrine therapy alone. The 5-year invasive disease-free survival was remarkably better, whether the recurrence score was 0 to 11 or the recurrence score was more than 12, but the P67 on neoadjuvant hormone therapy reduced to less than 10%. The 5-year IDFS is 93%, which suggests that if we use such adapted mechanisms in our clinical practice, we can reduce the use of neoadjuvant chemotherapy. Also, in the node negative or node positive, you can easily see that a recurrence score 12 to 25 having a remarkable reduction in P67. On the right hand side, there is no difference in the disease-free survival. So with this, we also know and we also appreciate this slide that in a post-menopausal, this whole discussion was for a pre-menopausal female. In a post-menopausal female, we are aware that neoadjuvant endocrine therapy can achieve equivalent response rates. It can achieve a response rate of 75%, whether you give chemotherapy such as one of the active regimens of adriamycin and paclitaxel or anastrozole. The response rates are equivalent, and this slide definitely has a meaning in a patient who is having a borderline tolerability of neoadjuvant therapy or is an elderly postmenopausal female. And this is also there in ASCO recommendations, which are I think 2021 recommendations. For a postmenopausal female, HR positive neoadjuvant endocrine therapy with an AI may be offered, but for a premenopausal female with an HR positive, HER negative early stage disease, neoadjuvant endocrine therapy should not be routinely offered outside a clinical trial. And I think this slide actually sums up a lot about what I have discussed. Is majorly about premenopausal early breast cancer. Sentinel lymph node biopsy, I think, has been discussed in the debate extensively, and converting CN1, I mean a node positive to node negative after neoadjuvant chemotherapy was a debate in the preceding session, and the two debaters beautifully said that you have to use 2 agents, you have to follow the axillary ultrasound, you have to remove 3 nodes or more, and you have to use IHC with micromets so that you can adopt sentinel lymph node after NAC. Recommendation about how to follow. I think I have 30 seconds. I will be able to close the talk in 30 seconds. So you have to follow with clinical examination regularly if someone is on neoadjuvant therapy. Whatever baseline imaging was used, mammography, ultrasound, MRI, for loco-regional staging, the same staging has to be adopted and used. So with this, I would like to conclude, and this is my last slide. NACT in an early breast cancer is beneficial for a luminal B breast cancer for a high risk young patient, grade 3, 1 to 3 node positive, more than 2 centimeter size, luminal A breast cancer, as well as these patients can go for BCS. Who needs chemotherapy in N0, N1? We don't know exactly, but I wish that genomic risk score in the preoperative setting, dynamics of Ki67 after exposure to neoadjuvant endocrine therapy as an ADAPT trial, tumor burden with respect to 1 to 3 nodes or T size, but all these are not yet validated for the preoperative setting. In a node negative breast cancer, I would like to use TC, but in a 1 to 3 node positive EBC, I would like to use AC and T in a sequential manner. Yes, there are benefits of achieving BCS, controlling micrometastasis, achieving pathological CR at least in a luminal B breast cancer. The field is dynamic. The role of BRCA positive breast cancer in a hormone positive. On the other hand, CDK inhibitors combinations, such as the Neo Monarch trial, as well as a concept which conventionally we have been taught that we can't combine chemotherapy and endocrine therapy, are all being explored, and phase 2 data are available as well as phase 3 data are available for CDK inhibitor and hormone therapy, but we have to adopt them in the preoperative setting. Thank you.